Welcome to our first video on acyanotic congenital heart diseases. Let's begin. These are the topics we're going to discuss in this lecture. Let's start with atrial septal defect. On each of these topics, we'll cover introduction, clinical presentation, diagnosis, treatment, and complications. Atrial septal defect refers to a defect in the interatrial septum. During the development of interatrial septum, in the embryonic period, failure of closure of ostium primum leads to the ostium primum ASD. The more common form is the ostium secundum ASD, which occurs when the ostium secundum fails to close. In fetal life, the pressure in the right atrium is greater than the left atrium. This is reversed after birth when the lungs expand and the foramen ovale closes, resulting in a greater pressure in the left atrium. This pressure difference creates a left-to-right shunt through the atrial septal defect. ASD can be isolated or associated with Down syndrome, fetal alcohol syndrome, and Holt-oram syndrome. Here's an illustration showing the difference between ostium primum type ASD and ostium secundum type ASD. Notice that in primum ASD, there's a failure of fusion of septum primum with endocardial cushion, while in secundum ASD, there is a hole in the center of atrial septum, either due to incomplete growth of septum secundum or increased resorption of septum primum. Both of them leave a gap in the atrial septum through which the blood can flow from one atria to the other. Patients may remain asymptomatic if the defect is small. A large size defect can lead to heart failure with poor weight gain and exercise intolerance, recurrent bronchopulmonary infections, and hepatomegaly. Atrial septal defect is a non-cyanotic condition unless the shunt is reversed, which is known as Eisenmenger syndrome. It occurs when there is uncorrected left-to-right shunt, gradually leading to pulmonary arterial hypertension, right ventricular hypertrophy, and shunt reversal, in which case cyanosis is evident. Clinical clues of ASD include systolic ejection murmur, best heard at the left second intercostal space. This is caused by increased blood flow through the pulmonic valve. Patients typically have wide, fixed splitting of the second heart sound because the increased blood flow through pulmonic valve delays its closure as well. Parasternal heave can also be found. It is a palpable precordial impulse that occurs due to right ventricular hypertrophy. Now let's move on to the diagnosis. A chest X-ray reveals enlarged right atrium, right ventricle, and pulmonary arch. Increased pulmonary vascular markings may also be demonstrated. ECG may show P pulmonale, representing an enlarged right atrium and signs of right ventricular hypertrophy, such as right axis deviation and right bundle branch block. Echocardiography reveals an interatrial communication and is the most accurate test. Here's a chest X-ray showing the features of ASD. Notice the enlarged size of right atrium and right ventricle, due to increased blood flow received from left atrium via the defect. Also appreciate these prominent pulmonary vascular markings, which are seen due to increased blood flow in pulmonary system. This is how ASD appears in an echocardiogram. Hopefully we can appreciate this gap in the atrial septum, which serves as a communication channel between the two atria. Here's an ECG showing negative QRS complex in lead 1 and positive QRS complex in lead AVF, indicating right axis deviation in ASD. Also, please notice these peaked P waves, known as P pulmonale, which occurs due to right atrial dilation. Most cases of atrial septal defect require no treatment and undergo spontaneous closure. However, surgery or percutaneous transcatheter closure is indicated in symptomatic patients and when there is significant left-to-right shunting. Moving on to complications. Atrial septal defect may lead to paradoxical embolization, increasing the risk of stroke. Paradoxical embolization refers to the embolus originating from venous system that travels from right atrium to left atrium via the septal defect, bypassing the lungs. Other complications include atrial arrhythmias, pulmonary hypertension, and heart failure. A 45-year-old woman is evaluated in the hospital for right facial droop and right arm weakness. 4 days ago, she was admitted with swollen and erythematous left leg. Initial ultrasound with Doppler revealed impaired blood flow in the deep femoral vein. She was started on intravenous unfractionated heparin. The physical exam shows right facial and arm weakness along with sensory loss. Cardiac auscultation is significant for fixed split of S2, which congenital cardiac anomaly most likely accounts for this patient's current condition. This woman was initially admitted with swollen and erythematous left leg. Initial ultrasound with Doppler revealed impaired blood flow in the deep femoral vein, suggesting deep venous thrombosis. She was started on intravenous unfractionated heparin. Today, the physical exam shows right facial and arm weakness along with sensory loss. These are the signs of the left middle cerebral artery stroke. The stroke in this patient was most likely caused by her venous thrombus. When the venous thrombus enters systemic circulation and causes end-organ ischemia, this is known as the paradoxical embolism. Cardiac auscultation is significant for fixed split of S2. This is the classic sign of an atrial septal defect. Therefore, the atrial septal defect is the most likely underlying cardiac anomaly that accounts for the paradoxical embolism in this patient. Now let's move on to ventricular septal defect. Ventricular septal defect is the most common congenital heart defect. It is characterized by a defect in the interventricular septum, most commonly in the membranous part of the septum. It can be isolated or associated with other conditions such as Down syndrome, Fetal syndrome, and Edwards syndrome. Here's an illustration showing a VSD. Notice this defect in the ventricular septum, which allows blood to flow from one ventricle to the other. Patients with a small defect in the interventricular septum are mostly asymptomatic. Patients with medium to large defects can present with failure to thrive, fatigue, dyspnea, with respiratory distress. Clinical examination may reveal a high-pitched holosystolic murmur heard over the lower left sternal border. The intensity of the murmur can be increased by maneuvers that increase the left ventricular afterload or preload. These maneuvers allow greater flow through the defect, increasing left to right shunting and murmur intensity. Some examples include hand grip, squatting, and passive leg raising. A mid-diastolic flow murmur can also be heard at the apex due to increased blood flow through the mitral valve. A loud pulmonic component of the second heart sound S2 can also be appreciated. Diagnosis of VSD is strongly correlated with the clinical presentation. Chest X-ray reveals enlarged left atrium and left ventricle with increased pulmonary vascular markings. Left ventricular hypertrophy due to volume overload can be appreciated in the ECG as left axis deviation. Similarly, right ventricular hypertrophy in Eisenmenger syndrome can be seen in the ECG as right axis deviation. Echocardiography is the most accurate test. It shows interventricular communication. Here's a chest X-ray showing the features of advanced VSD. Hopefully we can appreciate cardiomegaly and notice that only right ventricle is dilated, and there is no dilation of right atrium. This is in contrast to ASD, in which both right atrium as well as right ventricle are dilated. Also, there are prominent pulmonary vascular markings due to increased pulmonary blood flow. The Doppler echocardiography is showing the blood flow from left ventricle to right ventricle, suggesting the presence of VSD. Now let's talk about treatment of VSD. Small defects may close spontaneously and hence should be followed up by a regular echocardiography, whereas a surgical intervention with patch repair is required when there is large VSD and uncontrolled symptoms. Other indications include signs of mild to moderate pulmonary hypertension and significant left to right shunting with left ventricular dilation. Complications can arise if VSD doesn't close spontaneously or is not repaired in time. Heart failure, pulmonary hypertension, and cardiac arrhythmias are among the common ones. Infective endocarditis is also a possible complication. Let's try a question. A 6-year-old girl is brought to the physician by her parents for a routine checkup. She has no specific complaints. Cardiac auscultation reveals a holosystolic murmur at the left sternal border along with loud P2. ECG shows right axis deviation. Chest X-ray is significant for enhanced pulmonary vascular markings. What is the most likely diagnosis? This young girl has a holosystolic murmur at the left sternal border, along with loud P2. ECG shows right axis deviation. Chest X-ray is significant for enhanced pulmonary vascular markings. All these findings suggest the diagnosis of ventricular septal defect. Ventricular septal defect allows blood flow from the left ventricle to the right ventricle, leading to right ventricular hypertrophy with axis deviation. Additionally, increased right ventricular preload leads to pulmonary hypertension that accounts for loud P2 and enhanced pulmonary vascular markings. Let's end our lecture with a board-style question. A newborn female presents to the office due to her parents noticing persistent gasping for air. On physical examination, there is a high-pitched holosystolic murmur present when auscultating the lower left sternal border. The patient is sent for chest X-ray, which shows a dilated left atrium and left ventricle, as well as increased vascular markings in the lung fields bilaterally. Which of the following conditions is most often associated with this patient's current presentation? A. Down syndrome. B. Turner syndrome. C. Klinefelter syndrome, or D. XXX syndrome. A newborn presents to the office due to a persistent gasping for air, which shows that the infant is dyspneic and possibly in respiratory distress. The patient has a high-pitched holosystolic murmur, heard best over the lower left sternal border, a dilated left atrium and ventricle, and increased vascular lung markings. All the above are signs of a ventricular septal defect, or VSD. VSDs are most commonly associated with trisomy 13, 18, and 21, also known as Patau syndrome, Edwards syndrome, and Down syndrome respectively. Therefore, answer choice A is the correct answer. Here is a slide reminding us of VSD. Let's discuss other answer choices. Answer choice B is incorrect because Turner syndrome is associated with bicuspid aortic valve and aortic root dilation, not VSD. Answer choice C is incorrect because Klinefelter syndrome is associated with symptoms of decreased testosterone, not VSD. Answer choice D is incorrect because XXX syndrome is associated with few or no symptoms, not VSD. And that concludes the section.